Hypotension with pulmonary edema in severe hypertrophic obstructive cardiomyopathy is treated with A. Dobutamine, B. Nitroglycerin, C. Metoprolol and noradrenaline, D. All of the above. Correct answer C. Metoprolol and noradrenaline. Treatment with inotropes and vasodilators may be life-threatening in those cases of severe HOCM presenting with hypotension and pulmonary edema. Instead, beta blockers and vasoconstrictors like phenylephrine or noradrenaline should be used to improve the hemodynamic status in HOCM. Bariatric surgery is recommended for CABG patients if their BMI is more than A. 20 kg per square meter body surface area, B. 25 kg per square meter body surface area, C. 30 kg per square meter body surface area, D. 35 kg per square meter body surface area. Correct answer D. 35 kilograms per square meter body surface area. As per the American Heart Association Guidelines 2015, bariatric surgery is recommended for coronary artery bypass grafting patients if their BMI is more than 35 kilograms per square meter body surface area, if therapeutic lifestyle modifications have failed to produce adequate weight loss. It has been given a Class 2B recommendation with level of evidence C. Class 1 indication for coronary angiography in hypertrophic cardiomyopathy as per 2014 ESC guidelines. A. Adult survivors of cardiac arrest, B. Sustained ventricular tachyarrhythmia, C. Severe stable angina, D. All of the above. Correct answer D. All of the above. Additional Class 2A recommendations would be in those with intermediate pretest probability of coronary artery disease and in those above 40 years of age prior to septal reduction therapy. Contraindications to beta blocker includes all except A. Bradycardia, B. Hypotension, C. Severe bronchospastic airway disease, D. Compensated heart failure. Correct answer D. Compensated heart failure. Earlier, heart failure was considered a contraindication for beta blocker therapy, but now beta blockers are a part of standard of care in heart failure as they have been shown to reduce mortality and morbidity in heart failure. Still, it is not wise to initiate beta blocker therapy in decompensated heart failure on intravenous diuretics or inotropic support. Beta blockers are initiated after initial stabilization, that too in small doses, and titrated upwards to the maximum tolerated doses. The beta blockers of proven benefit in heart failure are carvedilol, bisoprolol, and metoprolol succinate. Beta blockers with intrinsic sympathomimetic activity are not preferred in the treatment of heart failure. Carvedilol has the added advantage of associated vasodilatory activity and has been even shown to be superior to metoprolol in one study. But the drawback of the comparison was that it was not the extended release preparation of metoprolol which was compared. Recommended view for measuring left ventricular thickness by echocardiography in hypertrophic cardiomyopathy. A. Parasternal long axis view by 2D, B. Parasternal long axis view by M-mode, C. Short axis by 2D, D. None of the above. Correct answer C. Short axis by 2D. As per the ESC 2014 guidelines, short axis two-dimensional measurements of all LV segments from base to apex is recommended to measure the maximum thickness of the left ventricular wall in hypertrophic cardiomyopathy. LV maximum thickness is a factor used for risk stratification with a cutoff value of 30 mm. Measurement of LV thickness by M-mode in parasternal long axis view, which is the most common method of LV measurements, is likely to give erroneous results due to oblique cuts. Moreover, it will miss out localized hypertrophy as in apical variety of HCM. Position used to prevent airlock in the right ventricle in air embolism. A. Left lateral decubitus, B. Right lateral decubitus, C. Supine, D. None of the above. Correct answer A. Left lateral decubitus. Left lateral decubitus position moves the air away from the right ventricular outflow tract, relieving the airlock. Air embolism is usually venous, though arterial air embolism is also possible. An important example is coronary arterial embolism during coronary angiography or intervention. Volume expansion and oxygen administration are two simple measures. Further entry of air into the circulation should be prevented by appropriate measures. If large volume of air is present in the right heart, aspiration using a central venous catheter is also an option. 100 to 500 ml of air has been considered to be lethal dosage in human beings. Advantage of mineralocorticoid receptor antagonist for hypertension with left ventricular dysfunction. A. Reduced myocardial fibrosis. B. Prevention of ventricular remodeling. C. Reduction in arrhythmia. D. All of the above. Correct answer D. All of the above. Mineralocorticoid receptor antagonists spironolactone and eplerenone are useful for treatment of hypertension in those with left ventricular dysfunction due to the added benefits of reduced myocardial fibrosis, prevention or even reversal of left ventricular remodeling, and reduction of arrhythmogenesis. Perioperative use of beta blockers in CABG is A. Class 1 recommendation, B. Class 2A recommendation, C. Class 2B recommendation, D. Class 3 recommendation. Correct answer A. Class 1 recommendation. As per the 2015 American Heart Association guidelines on secondary prevention after CABG, all patients should be given beta blockers perioperatively to prevent postoperative atrial fibrillation, ideally to be started before surgery if there is no contraindication. It is a class 1 recommendation with level of evidence A. Right ventricular outflow tract obstruction with hypertrophic cardiomyopathy would favor a diagnosis of A. Danon disease, B. Anderson-Fabry disease, C. Noonan syndrome, D. Pompe disease. Correct answer C. Noonan syndrome. Even though increased thickness of right ventricular free wall can occur in both Anderson-Fabry disease and Noonan syndrome, RVOT obstruction along with HCM is characteristic of Noonan syndrome. Dynamic LVOT obstruction can occur in A. Hypertrophic cardiomyopathy, B. Calcification of posterior mitral annulus, C. Hypovolemia, D. All of the above. Correct answer D. All of the above. In addition to these, dynamic LVOT obstruction can also occur in hypercontractile states and sometimes even in hypertension. Curved ST segment elevation in lateral leads in hypertrophic cardiomyopathy is suggestive of A. Lateral wall myocardial infarction, B. Apical aneurysm, C. Coronary vasospasm, D. None of the above. Correct answer B. Apical aneurysm. Curved ST segment elevation in lateral leads in hypertrophic cardiomyopathy can be due to small apical aneurysm formation in those with apical or distal hypertrophy. This can be associated with myocardial scarring. The small aneurysms may only be detected by cardiac magnetic resonance imaging, contrast ventriculography, or myocardial contrast echocardiography. Northwest QRS axis in hypertrophic cardiomyopathy is most likely due to A. Fabry disease, B. Noonan syndrome, C. Danon disease, D. None of the above. Correct answer B. Noonan syndrome. In Noonan syndrome, extreme hypertrophy of the basal region of the left ventricle, often involving the right ventricular outflow tract, is responsible for the extreme northwest axis. Diagnosis of hypertrophic cardiomyopathy in a first degree relative by European Society of Cardiology 2014 guideline needs left ventricular wall thickness of A. 15 mm or more, B. 14 mm or more, C. 13 mm or more, D. 12 mm or more. Correct answer C. 13 mm or more. Primary diagnosis, not in a first degree relative, needs thickening of left ventricular wall in any of the segments of 15 mm or more, not explainable by abnormal loading conditions like hypertension or aortic stenosis. The thickness can be measured by any of the imaging modalities like echocardiography, cardiac magnetic resonance imaging, or computed tomographic imaging. In a first-degree relative of a person with hypertrophic cardiomyopathy, the cutoff value needed is lower at 13 millimeters. Strongest risk predictor in hypertrophic cardiomyopathy. A. History of sudden cardiac death in multiple family members. B. Previous cardiac arrest or sustained ventricular arrhythmia. C. Septal thickness more than 30 millimeters. D. None of the above. Correct answer B. Previous cardiac arrest or sustained ventricular arrhythmia. Septal thickness of more than 30 millimeters is one of the weakest predictors. Family history of sudden cardiac death is important, more so if there are multiple affected family members. But the strongest predictor of all is a previous history of cardiac arrest or sustained ventricular arrhythmia in the same individual. Pulmonary thromboendarterectomy is the treatment of choice for A. Primary pulmonary hypertension, B. Eisenmenger syndrome, C. Chronic thromboembolic pulmonary hypertension, D. Massive pulmonary embolism. Correct answer C. Chronic thromboembolic pulmonary hypertension. Majority of patients with CTEPH have good relief of symptoms with pulmonary endarterectomy, and surgical mortality is around 5% in expert centers. Responders to surgery have near normalization of hemodynamics. Non-responsiveness could be due to the presence of pulmonary microvascular disease. The procedure is done under deep hypothermia and circulatory arrest. Pulmonary endarterectomy is done through the medial layer of the pulmonary arteries and is different from the surgical embolectomy done for acute pulmonary embolism. Only thrombi in main, lobar, and segmental pulmonary arteries are accessible. Only those in NYHA functional class 3 to 4 are considered for this truly major surgery, which takes several hours to perform. Most important complication after alcohol septal ablation for hypertrophic obstructive cardiomyopathy is A. Heart failure, B. Incomplete resolution of left ventricular outflow gradient, C. Complete heart block requiring permanent pacemaker, D. None of the above. Correct answer C. Complete heart block requiring permanent pacemaker. Alcohol septal ablation is popular in Europe as a less invasive form of septal reduction therapy than surgical myectomy for relief of left ventricular outflow obstruction in hypertrophic obstructive cardiomyopathy. But the procedure has a 7 to 20% risk of permanent atrioventricular block requiring permanent pacemaker implantation. But the risk has been significantly reduced by using intra-procedural myocardial contrast echocardiography to assess the territory of supply of the septal branch of left anterior descending coronary artery. Riociguat used in the treatment of pulmonary arterial hypertension is a phosphodiesterase 5 inhibitor, B. Soluble guanylate cyclase stimulator, C. Endothelin antagonist, D. Calcium channel antagonist. Correct answer B. Soluble guanylate cyclase stimulator. Riociguat is a novel drug for the treatment of pulmonary arterial hypertension with a dual mode of action. It acts along with endogenous nitric oxide as well as by stimulating soluble guanylate cyclase by a mechanism independent of nitric oxide. It has been evaluated in Patent 1 and Patent 2 trials. Complete AV block requiring permanent pacemaker implantation is more likely after A. Coronary artery bypass grafting, B. Aortic valve replacement, C. Mitral valve replacement, D. None of the above. Correct answer B. Aortic valve replacement. Complete heart block can occur after aortic valve replacement as the conduction system is closely associated with the location of the aortic valve. Pre-existing extension of calcification from aortic valve to the conduction system can cause complete heart block. This can be accentuated by the pressure of the artificial valve on the conduction system. Injury to the conduction system can also be due to sutures of the valve ring impinging on it. The pressure due to the valve on the calcareous material around the conduction system is responsible for complete heart block, which occurs in sutureless aortic valve replacement. Injury to surrounding tissue causing edema and compression of the conduction system is a potential cause of reversible postoperative complete heart block. Negative predictive value of echocardiography in pulmonary embolism: A 20 to 30%, B 40 to 50%, C 60 to 70%, D 80 to 90%. Correct answer B 40 to 50%. Negative predictive value of echocardiography in pulmonary embolism is only 40 to 50%. Hence, a negative result on echocardiography cannot rule out pulmonary embolism. Similarly, echocardiographic evidence of right ventricular systolic dysfunction can occur in cardiac and respiratory conditions other than pulmonary embolism. Right ventricular dilation on echocardiogram may be noted in about a quarter of patients with pulmonary embolism and is useful in risk stratification. Nevertheless, being a bedside investigation which is widely available, it is often next only to electrocardiogram and chest X-ray in sequence of investigations for pulmonary embolism. Which of the following is not useful in the treatment of hypertrophic obstructive cardiomyopathy? A. Verapamil, B. Metoprolol, C. Isoprenalin, D. Disopyramide. Correct answer C. Isoprenalin. Isoprenalin is an inotropic agent which will increase the myocardial contractility and thereby the obstruction in hypertrophic obstructive cardiomyopathy. Ventilation perfusion scan is preferred over CT angiography for detection of pulmonary embolism in A. Pregnancy, B. Contrast allergy, C. Multiple myeloma, D. All of the above. Correct answer D. All of the above. Radiation dose for ventilation perfusion scan is 1.5 millisieverts, while that for computed tomographic pulmonary angiography is 2 to 6 millisieverts. Hence, VQ scan is preferred in young individuals, especially females. It can also be used in outpatients with low clinical probability of pulmonary embolism. As it avoids iodinated contrast, VQ scan is also the imaging of choice in those with severe renal failure and in persons with multiple myeloma and paraproteinemia. Administration of intravenous contrast agents can cause renal failure in those with paraproteinemia. Which of the following are phenocopies of hypertrophic cardiomyopathy? A. Fabry disease, B. Noonan syndrome, C. Friedreich ataxia, D. All of the above. Correct answer D. All of the above. Phenocopies of hypertrophic cardiomyopathies are diseases in which hypertrophy of the left ventricle occurs similar to that in hypertrophic cardiomyopathy but are genetically different entities. Cardiac specific glycogen storage disease also mimics hypertrophic cardiomyopathy. In some situations, identification of phenocopy may be important, as in Fabry, in which disease course may be altered by replacement therapy with agalsidase alpha or beta. Genetic testing is also useful in identifying phenocopies of hypertrophic cardiomyopathy. Recurrence rate of venous thromboembolism at 1 year: A 6%, B 13%, C 20%, D 25%. Correct answer B 13%. Later recurrence of venous thromboembolism, usually after discontinuation of anticoagulation, is around 13% at 1 year, 23% at 5 years, and up to 30% at 10 years. Early recurrence while on anticoagulation is around 2% at 2 weeks, 6.4% at 3 months, and 8% at 6 months. Risk factors for early recurrence are presence of active cancer and failure to achieve therapeutic anticoagulation levels. Antihypertensives to be avoided in heart failure include all of the following except A. Verapamil, B. Moxonidine, C. Diltiazem, D. Enalapril. Correct answer D. Enalapril. Enalapril is one of the recommended drugs for hypertension in heart failure. All the other drugs have been shown to produce worsening of heart failure. Verapamil and diltiazem have negative inotropic effects and hence to be avoided in those with left ventricular systolic dysfunction. Moxonidine has been associated with increased mortality in patients with heart failure. Advantages of eplerenone compared to spironolactone include all of the following except A. Lower progestational effect, B. Lower anti-androgenic effect, C. Lower chance of gynecomastia, D. Lower chance of hyperkalemia. Correct answer D. Lower chance of hyperkalemia. Eplerenone has more specific effect on aldosterone receptors rather than other steroid hormone receptors. Anti-androgenic effect is responsible for gynecomastia and progestational effect for abnormal vaginal bleeding, which can be associated with the use of spironolactone. Chances of hyperkalemia are similar with spironolactone and eplerenone. Nitroglycerin is contraindicated in myocardial infarction associated with A. Hypertension, B. Left ventricular failure, C. Angina, D. Right ventricular infarction. Correct answer D. Right ventricular infarction. Nitroglycerin infusion is useful in the treatment of hypertension, left ventricular failure and angina in the setting of acute myocardial infarction. In inferior wall myocardial infarction associated with right ventricular infarction, nitroglycerin can lead to hypotension as it lowers the preload and thereby the right ventricular filling and output. Drug which should not be taken within 24 hours of nitrate intake and vice versa. A. Beta blocker, B. Calcium channel blocker, C. Alpha blocker, D. Sildenafil. Correct answer D. Sildenafil. Administration of nitrates by any route to those who have taken sildenafil during the past 24 hours can result in severe hypotension. Any such inadvertent occurrences should be treated with fluid resuscitation and alpha-adrenergic agonists. In case of angina in a person who has taken sildenafil during the past 24 hours, anti-anginal agents other than nitrates have to be considered to avoid this interaction. Sildenafil is a phosphodiesterase 5 inhibitor. Drug of choice for hypertension in a person with coronary artery disease and angina pectoris. A. Alpha blocker, B. Beta blocker, C. Calcium channel blocker, D. Angiotensin receptor blocker. Correct answer B. Beta blocker. Beta blockers decrease myocardial oxygen demand and hence relieves angina pectoris. Both the negative inotropic and negative chronotropic effects of beta blockers contribute to this effect. This has led to the strong recommendation for beta blockers for management of hypertension in those with coronary artery disease and angina pectoris. Cardioselective beta blockers without intrinsic sympathomimetic activity are preferred in this context. Severe bronchospasm, sinus or atrioventricular conduction disturbances, and decompensated heart failure are relative contraindications for the use of beta blockers. Beta blockers shown to be useful in heart failure include all except A. Carvedilol, B. Metoprolol, C. Bisoprolol, D. Atenolol. Correct answer D. Atenolol. Atenolol is a hydrophilic beta blocker while the rest are lipophilic. Trials showing efficacy in heart failure. Carvedilol, COMET trial. Metoprolol, MERIT-HF trial. Bisoprolol, CIBIS trial. Anticoagulation for atrial fibrillation in hypertrophic cardiomyopathy is recommended when A. in all patients, B. when CHARGE-2 score is 2 or more, C. when CHARGE-2 VAS score is 2 or more, D. none of the above. Correct answer A. in all patients. As per the ESC 2014 recommendations, anticoagulation is recommended in all patients with atrial fibrillation in hypertrophic cardiomyopathy as the stroke risk is high, occurs in over 1/4 of patients. In those without AF but large left atrium of 45 mm or more, 48-hour Holter monitoring is recommended in 6 to 12 monthly intervals to look for atrial fibrillation. Potential options in case of high defibrillation threshold while testing ICD: A. Subpectoral implantation, B. Reversal of shock vector polarity, C. Adding a subcutaneous array, D. All of the above. Correct answer D. All of the above. Additional measures would be changing the shock tilt and including or excluding a superior vena cava coil in the shock vector. Drug contraindicated in hypertrophic obstructive cardiomyopathy: A. Digoxin, B. Metoprolol, C. Disopyramide, D. All of the above. Correct answer A. Digoxin. Digoxin should be avoided in HOCM because of its positive inotropic effect, which can exacerbate the left ventricular outflow tract obstruction. Metoprolol and disopyramide are useful in alleviating symptoms of HOCM due to their negative inotropic effect. Caution has to be exerted while using verapamil for its negative inotropic effect in this situation, as its vasodilatory effect can sometimes be deleterious in those with dynamic left ventricular outflow tract obstruction. Bone scintigraphy with 99mm technetium DPD is useful in hypertrophic cardiomyopathy to exclude A. HCM due to sarcomere protein mutations, B. Fabry disease, C. Danon disease, D. TTR amyloidosis. Correct answer D. TTR amyloidosis. Transthyretin, the precursor protein in senile systemic amyloidosis and familial TTR-related amyloidosis, is a tetrameric plasma transport protein synthesized in the liver. TTR-derived fibrils show avidity for bone tracers, especially 99mm technetium DPD.